Good morning, everyone. We'll go ahead and get started here. It's my pleasure to introduce Dr. Shailender Bhatia today. He did his medical school training in India before going to do internal medicine residency at the University of Connecticut, and then came out west for Hem-Onc fellowship at the University of Washington. He then joined the faculty here, and he's an assistant professor in the Division of Medical Oncology. He attends at the SCCA with a clinical focus in skin and renal cancers. He also has a specific interest in intra-tumoral therapies and other methods to stimulate the immune system against cancer. He's given lectures about these topics all across the region and won several awards, including the Best Clinical Application Paper of the Year in the Journal for Immunotherapy of Cancer. His research is quite well funded, and he's the lead investigator on several clinical trials. Just to name a couple of them, includes an injectable monoclonal antibody in the treatment of melanoma, and an injectable Toll-Like Receptor agonist in the treatment of Merkel cell carcinoma. He's going to talk to us today about intratumoral immunotherapy. What happens in there does not always stay there. Please help me welcome Dr. Bhatia.
Thank you. Well, it's my pleasure to be here this morning, and I want to thank for the kind invitation to present my research here. As a fellow, I trained here, and I have very fond memories of coming to this meeting and enjoying the coffee and the donuts. And I'm happy to see the tradition is still alive. And I also remember passing out on these desks sometimes, listening to these talks after a whole night of call. And I will try not to replicate that from this end today. So again, I'm excited about how my research has shaped over the last decade or so now, and one of the subcomponents of my research involves intratumoral immunotherapy, which is quite exciting and fascinating, and I hope to share some of that excitement with you today. So I have no relevant disclosures. And if you haven't been paying attention, immunotherapy of cancer has come around in a very big way. A few years back, there were a few naysayers who would be doing immunotherapy trials, and everybody else will probably walk out of the room when they would stand up to present their findings. But now it has completely changed, and people who were not believers, now they stand up on the podium and they claim to be having believers in immunotherapy all their life. And it's fascinating to see that from my perspective, because we have been trying to stimulate the immune system against cancer using various strategies for a long time, and now we are seeing wider applications of that concept across all cancer types. So cancer immunotherapy was actually was labeled as the breakthrough of the year by the Science magazine in 2013. And just last couple of weeks, there was actually a very nice story on cancer immunotherapy, the promise of it, the challenges for the patients to get access to it on the cover of Time magazine. So it's definitely catching a lot of attention. And why did I get excited about immunotherapy? For many of you who may have rotated on our green medicine rotation a few years back, there are many patients who are getting this very toxic treatment called high-dose interleukin-2. And it's essentially a cytokine which is given in very high doses, and the purpose is to stimulate the T cells against the cancer. And the patients who usually get treatment with this are patients with stage 4 melanoma or renal cell cancer, which are usually otherwise considered incurable. The treatment does not really work very frequently. So if you look at the response rates, it's only around 20%. If you look at the complete response rate, it's even lower, 5% or so. So 1 in 15, 1 in 16 people would actually get a complete response. But if you look at these survival curves, the beautiful thing about these patients who have responses is that these patients almost never recur. And the follow-up here is over 20 years. So, which tells us about the power of immunotherapy. When our immune system can be stimulated the right way, it has the power to eradicate cancer completely. And the assumption is that many of these patients are likely cured. However, this treatment also brings to attention a limitation that we have dealt with in many oncology drugs, specifically with immunotherapy, that drugs, when they are given systemically, especially in high doses, they can be very toxic. This particular treatment is actually given in the intensive care unit. Patients have a septic shock-like physiology and require pressors. So it's very toxic treatment. It works well when it works, but certainly we can do better. And indeed, we have been doing better. There has been a lot of excitement in melanoma and now in other cancers. So in melanoma, just to give you a history of melanoma, for 3 decades, there were trials after trials, phase 2, phase 3, which failed to improve survival in melanoma. And all that changed in 2010 when ipilimumab, which is the monoclonal antibody to CTLA-4, was the first trial to actually show an improvement in overall survival in these patients. And that led to bigger and better things. And now we have outstanding success with other systemic immunotherapies, anti-PD-1 antibodies, anti-PD-L1 antibodies, and these drugs are now being used across multiple cancer types. We recently also had the combination of ipilimumab and anti-PD-1 antibody nivolumab approved in melanoma as well. And if you look at how well these treatments work, it's actually quite fascinating. So ipilimumab, which is again associated with low response rates, around 20% or so, also has a toxicity rate of around 27%. So PD-1 that came around a couple of years back actually doubles the response rate and the toxicity is lower. So it's a win-win on both fronts. If we combine the two drugs, the response rates go further up because the immune stimulation is greater, but unfortunately the toxicity rate also goes significantly up. So this is the best data that we have so far, that with our immunotherapy, around 50% of the patients can be helped, but we still need to find ways to make immunotherapy work in the remaining 50%, and hopefully with much lesser toxicity. These toxicities are very severe, and they can be debilitating and affect quality of life in the long run sometimes. So we definitely need to do better, both on efficacy and the safety fronts. And this also tells us that the immune microenvironment in the tumor cells is quite complex, and it will take some creativity to actually lead to further improvements. So we know that tumor cells are good at hiding from the immune system. Even when the immune system can recognize the tumor cells, they have multiple mechanisms to suppress those immune cells, so they can secrete cytokines, which are immunosuppressive, or they can use other mechanisms like PD-1, PD-L1 expression to further render those immune cells exhausted. So how are we going to come across, or how are we going to counter this very challenging problem of overcoming immune suppression in the tumor environment? And for this, I think we need to draw inspiration from wherever it comes. And this is my source of inspiration. So this is Trump's policy on Syria. He says, I would bomb the bleep out of them, and I think the medical term for the bleep is stools. I would just bomb those suckers. That's right. I would blow the pipes. I would blow up every inch. There would be nothing left. And you know what? You will get Exxon to come in there, and in 2 months, you ever see these guys, how good they are, the great oil companies. They will rebuild that sucker, brand new. It will be beautiful. And that's the premise of what I've been doing over the last several years. So this is what intratumoral immunotherapy is all about. I would blow up every single inch. There would be nothing left. And you know what? You'll get those CD8 T cells to come in there. And in 2 months, you ever see these guys, how good they are, the great immune soldiers. It will all be beautiful again. So I want to just take a minute to distinguish between systemic and local immunotherapies here. So systemic therapies, essentially, they have a potential for global responses. They can address the tumors that are visible, but they can also address tumors that are invisible, subclinical or microscopic. And cancer is essentially a systemic disease. So we do need a systemic approach to make meaningful improvements in cancer outcomes. But systemic treatments also have systemic toxicities, and if somebody has solitary or oligometastatic disease, those systemic toxicities can be potentially be an overkill for that situation. The other limitation of systemic therapy is that when drugs are given intravenously, they can be metabolized rapidly, and there is a potential problem that the drugs may not reach where they need to reach. We always wonder about whether we are achieving adequate intratumoral drug levels, and we know that our ability to escalate the doses is quite limited because of those systemic side effects. So local treatments have the potential to overcome some of those limitations. First of all, they are going to be safer because the toxicities are most likely expected to be local. However, they also have some problems of feasibility. It's easier to do local treatments on superficial, easily palpable tumors, but when we are talking about deep visceral lesions, it's harder to do that on a repeated basis. The other big potential limitation is that treating a tumor locally may not actually result in a systemic response, and that's what I hope to convince you today, that indeed, some of the local therapies can actually result in systemic benefit. So hopefully, by the end of this talk, you will see some examples of that. So again, the potential advantages to intratumoral immunotherapy could be that it could be safer with less systemic side effects. Another potential advantage is that it has the potential to be broad. If we do immunotherapy in a local tumor, it can stimulate immune responses against a diversity of tumor antigens. We don't really need to know what those antigens are. As long as we use the right drug to stimulate the immune system, we have that potential for actually doing personalized medicine, which is unique to that person's flavor of tumor antigens. And then directing our energy onto the local tumor microenvironment has more of a potential to overcome the local immune suppressive mechanisms that exist in that microenvironment. But again, the question is, can the local benefits spill over into the systemic circulation? And that is my scientific hypothesis, that what happens in there does not always stay there. And you may remember these photos that leaked out a few years back. And I want to point out that this slide is HIPAA compatible. So we do want to focus on systemic benefit when we are doing these trials. How can we convince other people that we are indeed getting systemic benefits? I think the gold standard is if we have a non-injected lesion, preferably distant from the treated site, and if it regresses, we know that we are actually getting some sort of systemic benefit from our local therapy. Sometimes those lesions may not be available, and we settle with less convincing endpoints like prolonged stable disease or progression-free interval, which suggest a protective anti-tumor systemic immune response. Thirdly, we can also detect and track immune responses in the peripheral blood, but that's actually proving to be easier said than done. We have done several trials, we have done biopsies in the tumors, and sometimes we do see evidence of that, but it's actually a fairly challenging task to be able to track that consistently across all patients. So we have several trials going on at UW and SCCA, and I'm going to share some of those with you. So our trial number 1 is actually using intratumoral delivery of interleukin-12 DNA, and then we use in vivo electroporation. This trial is actually going on in Merkel cell carcinoma. And when I was training, I had no idea that I'll be working on a rare cancer, which I had never even heard of the name of. And it turns out Merkel cell carcinoma, it's a very aggressive skin cancer. The therapeutic options currently are suboptimal, although we are making huge advances in this field systemically. It's actually more aggressive than melanoma, 3 times the mortality rate of melanoma. Patients who have seemingly localized disease have a high risk of recurrence. And when people have metastatic disease, we use chemotherapy, which has a high response rate, kind of similar to small cell lung cancer. But the responses are very transient, usually lasting 3 to 4 months, and then tumors progress, and we don't really have good options for these patients. Right around 2008, there was a virus that was discovered, Merkel cell polyoma virus, and that has opened up a great deal of interest in this cancer, especially for immunology and immunotherapy. We now know that if CD8 T cells can infiltrate into the tumors, that is associated with markedly better prognosis. Something that was discovered by Kelly Paulson, who is a medical oncology fellow here. We also know that despite the reliance of Merkel cells on immune mechanisms, there are multiple mechanisms by which the tumors can actually evade the immune system. All that is fascinating. The real reason for me getting interested in this cancer was also that Dr. Niem, who's now the chief of dermatology, also joined our institution around 2006, and working on this cancer and having a dedicated lab researcher certainly offers opportunities to do collaborative science, which is otherwise not possible. So we were looking for new options in this disease with all that fascinating background on that. I came across this approach of interleukin-12 electroporation, and we decided to use that for this trial. So interleukin-12 is a very important cytokine in our adaptive immune responses. So it skews the immune response towards this T helper 1 phenotype, which then leads to protective CD8 and memory immune responses. And there was a lot of interest in using interleukin-12 for treatment of cancer in the 80s and 90s. And it turned out that it actually worked well in cancer immunotherapy. But in many trials, there was also a problem becoming increasingly apparent that it was very toxic when it was administered systemically. There was a fair bit of myelosuppression, GI bleeding, hepatitis, and actually a few patients died from those initial trials as well. And since then, it hasn't really been used systemically very much, but quite a few investigators have been trying to deliver interleukin-12 locally and hoping that it will improve its therapeutic index. So the way we decided to deliver it was that we used a plasmid of interleukin-12 DNA. We injected that into the tumors, and we followed up with the insertion of these electrodes, which would then generate electrical impulses. So the idea was that electrical impulses will transiently open up the pores of the cell membrane, the plasmid goes into the cell, and it gets trapped over there. And then the cells actually use the plasmid to produce interleukin-12 locally in the tumor microenvironment without any systemic spillage, without any of those bad side effects. So this was the first prospective clinical trial of immunotherapy in advanced Merkel cell. We got the trial started in 2012. It was a single institution study. The key eligibility criteria was that the patients had to have one injectable tumor, which I could feel and confidently get into with the injections and electroporation. The primary objective of this trial, which had 15 patients total, was we wanted to show that using this plasmid DNA and electroporation leads to increased local expression of the IL-12. So that was our primary endpoint. And then we hope that once we achieve this, first of all, it will be safe and tolerable, and then it will have local efficacy, but also systemic efficacy. And we also did some correlative studies to see the immune responses. The way we did the treatment was patients got 3 treatments in each cycle. Each cycle was 6 weeks long. The treatments were given on 3 days, days 1, 5, and 8. So you can imagine Monday, Friday, Monday schedule. And then they were done with the treatment. There were 2 cohorts of patients. One was loco-regional cohort, where we would normally do surgery and radiation. And in that cohort, treatment was done more as a neoadjuvant therapy. And then there was the cohort of metastatic patients who had disseminated disease. And this was the primary treatment for those patients. So again, treatment was done on days 1, 5, and 8. We treated up to 4 tumors in a given cycle, or sometimes if the tumors were big, we would select 4 zones in that treatment. We used this particular dose, and this is what the electroporation device looks like. So this applicator with an array of 6 needles, this is the one that goes into the tumors, and then it delivers 6 pulses at a fairly high voltage, 1300 volts. But each pulse is very small, a few microseconds, and the whole treatment is over in less than 3 seconds. So the treatment was safe and well tolerated. So even though we tried to numb the tumors with local lidocaine, most patients felt the electric shocks and reported it as pain. So that happened pretty universally in all treatment sessions. Now again, the duration of electroporation was only 3 seconds, so this was very transient, and patients felt absolutely fine after the treatment was over. They were able to bike the same day, play tennis the same day, but pretty much all patients had some degree of pain, and not surprisingly, women did much better than men. Their pain scores were much lower. And men, when they were asked to grade, many of them wanted to go beyond 10. Can I say 20? And I was like, no, just pick one number between 0 to 10. So again, most patients had some local pain. Some patients had local inflammation, which is actually a desired response. But there were no systemic side effects, especially when we talk about the severe side effects. Some of the patients had mild flu-like symptoms, but nothing extraordinary systemically. There were no serious adverse events. None of the patients discontinued the treatment due to adverse events. And this is just an example of the mild inflammation and some discoloration at the treatment site. So this is week 2 of treatment, day 8 probably. And this is a few weeks later. You can see some mild inflammation and some healing of the electroporation sites over there. So again, coming to our primary endpoint, we wanted to prove that the treatment actually works as intended. We wanted to see increased expression of IL-12 in the local tumor microenvironment. So for this, all patients had biopsies done pre and post treatment. The post-treatment biopsy was done on day 22, so 3rd week. And again, reminding you that the treatment was done on days 1, 5, and 8. So, this shows that most patients had increased IL-12 expression levels even 3 weeks after the treatment was administered, which is actually quite fascinating. When we give a drug orally or IV, usually the drugs are out of the system within a few days. The half-life is not that much. But with this approach, just doing 3 treatments, you could get increased expression of the protein for up to 5 weeks, and again, locally without any systemic side effects. So that's quite fascinating, and offers potential for using this technology to pretty much deliver any drug. We just need to figure out the DNA for the drug and inject it in the form of a plasmid and get local expression of otherwise potentially toxic drugs. So indeed, this increased expression of IL-12 in the local tumor microenvironment led to local regression. So this just shows the proportion of treated lesions with major regression, and around half of the treated tumors had major regression. This does not include the tumors which may have minor regression, less than 30%. And again, going back to our systemic or desire for systemic responses, we looked at distant lesion regression, and there were 3 out of 10 patients who had regression of their distant lesions, again suggesting that we were able to create a good systemic immune response. And these distant lesion regressions led to clinically meaningful improvement or outcomes in those patients. So there were 3 patients who were classified as partial response. One of these patients is actually a near complete response, had stage 4 disease, already had chemotherapy, and just got this treatment and is now in remission, complete remission 2.5 years later, which is fascinating, with just a few cycles of treatment locally without any systemic side effects, and already having exhausted other standard options, is in complete remission. There were 3 patients in Cohort A, which was the loco-regional cohort, and 1 patient had pathologic CR after those 3 treatments, remains free of recurrence, and another patient has been recurrence-free since over 3 years now. This is another example of a patient who had regression of both treated as well as untreated lesions. So this gentleman had multiple in-transit lesions in the leg. Some of those were bigger than others. He got 2 lesions treated at the first cycle, 4 lesions treated in the second cycle, and over time he had regression of not only the treated lesions but also distant non-treated lesions, and eventually had a confirmed partial response. And we did multiple biopsies on his tumors, and you can see that these are the post-treatment biopsies, these are the pre, and you can see emergence of or enrichment of this population in the tumor-infiltrating lymphocytes. This is specific for the Merkel cell polyoma virus. So again, suggesting some sort of immune response from the treatment, which we already knew clinically since his tumors were regressing, including distant lesions. This is a multispectral immunohistochemical image of pre- and post-treatment tumor on another patient in this trial. And you can see the CD8 T cells are represented by this color here, which may not project very well. But bottom line is you can see increased infiltration of T cells into the tumor microenvironment after the treatment. Unfortunately, in this patient, it did not lead to the desired response. And trying to tease out those mechanisms for that, it turns out that there is increased PD-L1 expression in the tumor microenvironment, which could possibly be one of the mechanisms of those immune cells that are able to infiltrate now, but they are rendered exhausted by the tumor cells. So conclusions of this trial were that this treatment approach leads to effective transfection and sustained expression of IL-12 protein in the tumor microenvironment. It was safe and well tolerated. It was associated with objective clinical responses, and seems to result in a local pro-inflammatory response, which in turn it seems to be promoting a systemic immune response. We also learned several lessons from this trial, and one of the lessons was that sometimes the disease is just too aggressive, for trying local immunotherapy. This was a patient with axillary lymph node mass, and we treated 4 zones in this patient, and you can see this almost tripled in size within a period of 4 weeks. So even if we got some good responses going on in these zones, the pace of disease was just too aggressive for the local immune response to overcome. And again, that points out to how should we select patients for this approach. So when I am seeing these patients in the clinic, I'm actually trying to evaluate their total burden of their disease, how fast are the tumors progressing, and perhaps most importantly, how much of the total tumor burden is going to be treated with intra-tumoral immunotherapy. In other words, what proportion of the total tumor burden is going to be treated versus left untreated, and then that kind of gives me a clue. Is it safe to do a treatment with intratumoral immunotherapy? And then also, it all has to be viewed in the context of what systemic therapy options are available for these patients. So that was the last trial, and this is another Trumpism, which I'm still trying to figure out. So I try to learn from the past, but I plan for the future by focusing exclusively on the present. So what is going on presently at SCCA with IL-12 electroporation? So we do have this phase 2 study in melanoma using exactly the same technique, similar treatment schedule, and we have seen impressive responses in that trial too. The data is still not mature, but this is just an example of those responses. This is an 82-year-old lady who comes from Wisconsin, loves to dance, and had this multiple in-transit metastases of melanoma in her leg. And her options were either to do a limb perfusion, which can be fairly debilitating, or some systemic immunotherapy, which had the chance of systemic side effects. And she was interested in exploring other options. So we treated her on this trial, and this is her almost a year later with fairly minimal disease. This is another patient who had multiple tumors on the sole of his foot, and we treated the tumors at the base of the foot. And he had the most intriguing evidence of systemic immune response. So he had multiple tumors up on his leg as well. And this is around 3 weeks after we started treatment on the trial. He started having inflammation of more proximal lesions. And it was all in a stepwise fashion. So first, this lesion got inflamed. 3 days later, this lesion got inflamed, and he also had some disease higher up. And so we could literally see the immune response traveling proximally, which was just fascinating. And this inflammation in these areas was also subsequently resulted in regression of those lesions as well. So again, going back to that systemic theme here. So we have been doing other trials as well, and I don't know if you have heard of attempts. These are some of the earliest attempts at cancer immunotherapy. So William Coley in 1890s dug up some literature and found out from his own experiences and the literature that cancer patients, when they got severe infections, some of them went into complete remission. So what he started doing was actually induce those infections by injecting bacteria into the skin, resulting in high fevers. And at that time, there were no antibiotics, and some of these patients would die. Some of those would survive and actually would have dramatic remissions of their cancer as well. So there is this whole field and companies trying to use Coley's toxins. And our next trial is essentially a refined version of that. So what we are using is this drug GLA, which is a Toll-Like Receptor 4 agonist. So Toll-Like receptors, they're expressed on our antigen-presenting cells, and the function is to identify danger signals from the pathogens. And then once that signaling cascade ensues, it leads to protective immune responses. And what this drug is, it's essentially a synthetic version of lipid A, which is a component of the endotoxin that we see in gram-negative bacteria. So this acts as an agonist for this Toll-Like Receptor 4. Interestingly, it's emulsified in shark liver oil. While working with this drug, I actually found out that sharks never develop cancers, which was fascinating. And so people have been studying different components of shark, trying to find out why they never develop cancers. And shark liver oil is being used in this drug as an emulsifier. Now, this drug is being used as an adjuvant in several infectious disease vaccination strategies, but we decided to use it intratumorally because of, again, it's easier to do that. And also, we were hoping for immune responses against that diversity of antigens that exist in the tumor microenvironment. This was a small pilot trial, 10 patients, supported by Life Sciences Discovery Fund, and also some internal consortium grants. And again, in this trial, we had 2 cohorts of patients, one with loco-regional, who just got 2 injections prior to their surgery and radiation. Both those patients are actually in remission, doing very well. And I'm going to talk about one of those patients in a minute. There were, at the time when we presented the data last year, there were 6 patients who had been treated in the metastatic cohort. These are patients with distant disease. And in the first cycle, they got 3 injections. These injections were given weekly. And then we delivered radiation for potential synergy and followed it up with more injections. And most of these patients got up to 2 cycles. Again, the treatment was safe and feasible. There were no serious side effects. As expected, we saw some local inflammatory reactions, no systemic side effects, did not seem to affect administration of subsequent therapies. This is the summary of efficacy. So in cohort A, 2 out of 3 stage 3B patients are continuing to be free of recurrence. Cohort B, there were 2 patients who have had very impressive near complete responses. And again, these are metastatic patients who typically would not live beyond a year, but they are completely disease-free at almost a 2-year time point now, with just a few injections into the tumors. So this is a patient in cohort A who had a tumor in a lymph node. He just got 2 injections of GLA into that lymph node, that had his surgery as planned. And he had a lot of inflammation prior to the surgery. And interestingly, the pathologist reported a complete response. There was no tumor left whatsoever. And looking at his tumor-infiltrating lymphocytes, this is a lymph node that was deeper to the tumor area, and there was a very high concentration of Merkel cell polyoma virus specific T cells in that lymph node that was draining the area where we actually injected the drug. This is another patient who had a more serious situation, stage 4 disease, biopsy proven, lymph node as well as bone metastases. And this slide shows his CD8 T cell status in around the tumor. And pre-treatment, you can see very few brown spots, which are the CD8 T cells, and most of those are associated with the stroma. They don't seem to be going into the tumor. This is just after 2 injections, day 22 post-treatment biopsy, and you can see many more of these CD8 cells, and they now seem to be going into the tumors, and this led to local regression, and now he has basically a complete remission for over 1.5 years. And again, the standard option for his treatment would have been chemotherapy, which does not work very well. And interestingly, he wanted these images, and now these images are actually his Facebook profile picture. So what else is going on in intratumoral immunotherapy? So it's actually come to age now. There's actually a drug which just got approved a few months back. It's a drug by Amgen, and what it is essentially is an oncolytic herpes virus, which is genetically engineered. So it can infect both normal cells, but it selectively replicates in the tumor cells, eventually leading to the destruction of the tumor cells, releasing antigens, and then also the DNA has codes for GM-CSF, which then attracts antigen-presenting cells onto the into the tumor microenvironment, leading to adaptive immune responses. And this is an example of how it works. Again, injected into some of these areas, we expect good responses locally, but as you can see, over time, the other non-injected areas seem to be fading away as well. And this drug was tested in a phase 3 trial and actually showed overall survival improvement in a subgroup of patients. And interestingly, there were 2 subgroups of patients. One had relatively localized disease, mostly confined to the skin, in-transit disease, or cutaneous metastases. And there was good evidence of benefit in that population. But when the disease stage got higher and people had visceral lesions or deep-seated lesions, that survival benefit went away, which also highlights one of the limitations of intratumoral immunotherapy, that if you're dealing with a greater burden of disease, the effects of local immune stimulation may not be powerful enough to overcome that local, to make a meaningful overall improvement. So that also points to the potential of combining these approaches with systemic immunotherapy. And as I shared with you earlier, there's so much action going on in systemic immunotherapy, and some of those drugs are very well tolerated. So the obvious next steps are to combine 2 safe therapies, local therapy with the systemic immunotherapy, and hopefully get synergistic immune responses. And this trial using the oncolytic herpes virus injected locally in combination with anti-PD-1 antibody is just started, and we are participating in that as well. Lastly, I want to emphasize one of the problems that exists with intratumoral immunotherapy is the feasibility of it. We are mostly restricted to treating lesions that are superficial, easily palpable, and less applicable to deep-seated lesions. But there may be a way around that. So radiation therapy is commonly used for treating cancer. And over the last few years, we are increasingly recognizing the immune modulatory effects of radiation. And that could be one way of doing local immunotherapy, perhaps in partnership with systemic immunotherapy, to increase the applicability of intratumoral approaches. And again, working on Merkel cell, we have been using this single dose, 8-gray dose, single fraction radiation, which works really well. This is a patient who had painful subcutaneous metastases on the back, got this 1 shot of radiation, and 1 week later, this is completely gone. This can be administered to deep-seated lesions, in this case, a mediastinal subcarinal lymph node, and again, dramatic response with no side effects. And there is some reason to believe that hypofractionated radiation may actually have better immunogenicity. So that opens up possibilities for combining this intratumoral potentially immunotherapy approach in combination with systemic therapies. And indeed, we have a trial going on for that as well, where we are using radiation in combination with the anti-CTLA-4 antibody. This is being led by Ramesh Rangan. So I'm going to conclude my talk here. So again, the take-home messages, hopefully from my talk, will be that local intratumoral immunotherapy can result in systemic immune responses, and those can be clinically meaningful. Toxicity is generally favorable with mostly local side effects. And again, combining local and systemic approaches may overcome some limitations of either approach and definitely deserve further investigation. Lots of people to acknowledge. I want to thank my mentors, John Thompson, Paul Neum, who have gotten me interested in what I'm doing right now and being wonderful collaborators. These trials that I shared with you, they're very labor intensive. A lot of work goes into it. And I'm fortunate to work with a very dedicated clinical research team. Lots of folks in the Paul Neum laboratory to thank, and certainly the rich expertise that we have around in this building. So with that, I will stop, and I'm happy to take some questions.
This is very exciting work, obviously, translating immunotherapy to actual good clinical response. I have a question specifically about Merkel cell, where antibodies against the Merkel cell virus turn out to be a tumor marker, as you know, and rising levels of the antibody reflect more active disease. What happens in the setting of immunotherapy to the levels of antibodies? Do they go up? Do they go down? Do they correlate with disease burden? And is there a clue to that in terms of shifting from Th1 to Th2 in that process?
Yeah, so that's a great question. So what you're referring to is that we have this antibody assay against the T antigen oncoprotein of Merkel cell virus, which was developed by you. It does correlate with tumor burden very well. And we actually use it very commonly in surveillance of our patients. So patients who have localized disease, have had surgery, we use that antibody test to follow those patients, and it helps to reduce the frequency of scans in those patients. And many times when we see the titer going up, we will order scans, and indeed we find metastases showing up. The application of that test to track disease burden in metastatic setting is not that clear quite yet. First of all, I think these antibodies have a longer half-life, and we need more prompt decision-making in the stage 4 setting because we can't wait several months to see when the antibodies go down. So we typically are doing scans in that setting for assessing disease burden. In our clinical trials, mostly with systemic immunotherapy approaches, we are tracking those antibodies with time and trying to figure out what happens to those. And so far, it looks like it does, again, correlate with disease burden. If our systemic immunotherapy is working, eventually the titer starts going down. But it does seem to lag behind the clinical scans. So we haven't really been using it in that setting as much. Whether we can use that to study humoral responses, I'm not quite clear on that because it really is more specific for tumor burden at this time. Yes?
Have you looked or considered regulatory T cells locally penetrate with their go perhaps down? If you consider that regulatory T cell magic is possible by using pressure, I wonder if one could actually use T-Rex as a effectively.
Yeah, so that's a great question. So the question is, can we use, or have we looked at Tregs as a marker of good immune response against the tumor? So we personally have not been paying much attention to the Tregs as conventionally evaluated by FOXP3 staining, for example. And we did try that initially, but in Merkel cells, we did not find a clear signal that that plays a role. But I think a lot of people are looking at that in other immunotherapy trials, and it turns out just looking at one component of the immune response is not proving to be sufficiently predictive of success. In many studies, it has been reported that probably looking at the ratio of T effectors to T regulatory cells can be a more robust correlate of good clinical response. But that, again, is fairly challenging. One thing I've realized with all these trials is even though we have superficial tumors, we can do multiple serial biopsies, there is so much sampling heterogeneity, which makes it very hard to interpret these serial biopsies with confidence. Unless we see a very clear signal of T cells infiltrating when they were not previously, sometimes it's very challenging to tease out these various components of the immune system. But that's something that certainly that needs to be looked. We just need to have better tools that are available more universally.
All right, we'll go ahead and close there. Thank you very much.
Great. Thank you.